Thank you everybody for joining us. I know it's everyone's busy and we appreciate you taking time out of your schedule. We are here tonight with Dr. Zachary Post. He's going to speak on modern hip and knee replacement techniques, robotics, and same-day surgery. Just go over a little bit of housekeeping. I'll do an intro and then he'll get started. If you take a look at the bottom of your screen, there is a box that says Q&A and it has a little question mark in it. If you have any questions during the presentation, you can go ahead and type them in there. Don't use the chat because we can't really see that always. It's kind of finicky. So just keep them in the Q&A. Dr. Post's presentation will be about 40 minutes, and then we'll have some time for questions at the end. I do ask that you keep your questions a little bit more general, nothing specific to your health in your case. If you have a very specific question, you can send it to me separately, and we can see if we can get an appointment set up for you. But we'd like to keep these kind of general that might apply to anybody. I will also put my phone number and my email in the Q&A or in the chat, and you can feel free to send me a text, an email, anything like that. If you have any other questions, if you want to schedule an appointment, I can help you with that. And with that, I will do a quick intro and then we'll get started. Dr. Zachary Post is a board-certified orthopedic surgeon. His expertise is in hip and knee joint replacement surgery, arthroplasty, and reconstruction. He is a leader in complex hip and knee reconstruction surgery. He received his medical degree from St. Louis University School of Medicine and completed his residency in orthopedic surgery at the University of Missouri in Kansas City. He completed a fellowship in hip and knee arthroplasty at Thomas Jefferson University Hospital in Philadelphia. Dr. Post previously practiced in Montana and Utah before calling Southern New Jersey his home. He's down the shore now. Throughout his time practicing medicine, he has authored numerous publications, helped design hip and knee implants, and has lectured internationally on the latest techniques in hip and knee replacement surgery. Dr. Post sees patients in our Egg Harbor Township office as well as our Manahawkin office. And with that, I will turn it over to you and enjoy.
Thanks, Kristen. Can you hear me okay? Everybody hear me all right?
Yep, yep.
Thank you for the introduction. That was actually sounds pretty good. I was like, that guy sounds good. Sure. I guess that's me.
That's you.
Anyway, thanks everybody for joining us. I want this to feel really pretty informal. I've prepared some slides to kind of give you an idea of sort of what we do with hip and knee replacement. And in addition to what we do, what's new and what's changed in a way that makes it an easier recovery for patients. Like I say, we reserved about half the time or about a third of the time for questions at the end. So if you've got questions, please don't hesitate. I mean, if you've got a question, almost certainly somebody else has that same question. So Kristen's going to be kind of managing that for us. But if you've got a question, type that in. And as they come up, you can kind of type them in as you go. Kristen already introduced me, but just to recap, I did my med school in St. Louis, and then I did an orthopedic surgery residency in Kansas City. On a lark, I was able to come to Philadelphia to train with Dr. Dick Rothman, who started the Rothman Institute. I left my training to go back and practice in Montana and Utah. And after a couple of years there and realizing it was much too cold for my wife's liking, Dr. Rothman invited me to come back. I included a couple of pictures. This one is a little bit of a time warp. This feels like yesterday, but this was me when I first came back to Philadelphia. I was young, still had a full head of brown hair, and three young kids. That was 15 years ago. This is a slightly more updated photo, but those kids have gotten bigger. In fact, our family, the significant event for us this summer was my oldest daughter got married, which is, I don't know what's next. I guess grandkids? Not totally sure I'm ready to embrace that, but time has gone fast. But we've loved living here in the Philadelphia area. And like I say, we're down at the shore, which we love. And I'm sure if you visited the shore, you would agree with us. It's a beautiful place to live, especially in the summer. Let's get right into this. I want to start talking about just hip arthritis and knee arthritis in general. We're going to kind of divide this into hip arthritis first, and then we'll talk about knee arthritis, and we'll kind of mix in sort of what we do and why it's new and why it's better. A problem with a hip pain is it's unclear what exactly is your hip? People say, I think my hip hurts, but where is your hip, right? Is your hip in the back? Is it in the front? Is it on the side? And am I the only person who has hip pain? Well, if you do have hip pain, good news, you're not the only person. In fact, it's common, very common. In fact, as the population of the United States ages a little bit, we're starting to see significant increases in the amount of arthritis and hip arthritis in particular. In fact, it's estimated that in 2020, so this is going back a few years, 47 million people in the United States had some form of arthritis. That equates to about 21% of people over the age of 60. So, uh, if that's you, you are not alone. There are several people who are in the same grouping as you, have some arthritis, have some hip pain. That number is increasing too. Like I said, as the population gets a little bit older, we expect that the number will go to 60 million by 2030. So, hip arthritis and knee arthritis are common. If you don't know somebody who has had a knee replacement, and I'm sure you do, then you'll probably soon meet somebody or somebody who's had a hip replacement. It's common. Look around. 1 in 5 people have got significant arthritis that might require some type of arthroplasty or joint replacement. Hip arthritis is traditionally, we describe hip arthritis as groin pain. People say they've got pain in their low back or they've got pain on the outside of their hip. But true hip arthritis, meaning the ball of the hip and the socket are worn out, presents as groin pain. If you look at that area of your body, which is probably pretty intimate, but where the groin crease is at, that's where the hip folds, and that's why that groin crease is there. People who have hip arthritis typically complain of pain when walking. And then another hallmark, it seems to hurt at night. And there's nothing worse than having your hip hurt at night because you're trying to get some rest. And when you can't sleep, it doesn't take very many days of not being able to sleep before you're miserable. People who have hip arthritis also complain of what we call loss of motion. The hip just doesn't move as well. The toes seem to turn out a little bit when they walk. They complain of difficulty putting on their shoes. In fact, shoes and socks are a common complaint. We often joke in the office when somebody comes in for hip pain that the guys who have, and the guys and girls who have hip arthritis typically are wearing slip-ons. It's kind of a dead giveaway because tying their shoes is difficult. It's hard to reach down that far to put your shoes on. How do you know if you've got hip arthritis? Well, it comes down to the x-ray. An x-ray is an exam that we'll do in the office where we'll take a picture of the inside of your hip where we can see the bones and we can see if they're healthy or they're not healthy. This is an example of a healthy hip. And now the hip is what we call a ball and socket joint. You can see that the ball of the femur, which is the top part of the hip here, is nice and round. In addition to a round head of the femur, there's a little bit of space here between the socket. We call that the cartilage space. So the idea here is good space means good hip and probably not very painful hip. Now, in contrast to that, this is an example of an arthritic hip. You can see the space is gone. You probably have heard the term bone-on-bone arthritis. This is a good example of bone-on-bone arthritis. I mean, orthopedic surgeons are not very creative. We just describe what we see. When the bones start touching themselves, we call it bone-on-bone. And you can see right here, that bone is starting to rub against itself. You could also imagine that hurts. It's difficult to move that hip and it causes pain with walking and all kinds of activities. Let's talk about what causes hip arthritis. There are several causes, most of which we're not really sure what causes it, but there are a few we understand very clearly. The first is trauma. Either if you played in the NFL or if you didn't, most of us didn't, but a previous trauma. Maybe you had a bike accident when you were a kid. Maybe you got hit playing football when you were in junior high. Some kind of trauma very commonly leads to hip arthritis. And so people, when we see people in the office and they say, I don't know what happened, and then they start thinking back, I did playing sports as a kid or I this or that. Very often there's a history of trauma that has led to the arthritis that they're now experiencing. Genetics. Hip arthritis tends to run in families. Again, another common theme when we're in the office with patients who have a bad hip is they'll say, my, my mom had her hip replaced, or my dad Or my brothers, I have three brothers, two of them have had hip replacements. There's some complicated genetic connection here we don't totally understand, but it's very common for patients who have hip arthritis to have somebody in the family who also has hip arthritis. There are certain drugs which are associated with hip arthritis. So, steroids and alcohol abuse are very commonly associated with early onset hip arthritis. So, if this is your medicine cabinet, or this is your medicine cabinet, you might be at an increased risk of developing hip arthritis. So, we talked about a bad hip. And again, here's that picture or another picture of a bad hip. You can see sort of the classic findings where the ball is no longer round, the space is gone, and the bone is starting to rub against itself. These are the classic signs of hip arthritis. We treat that with hip replacement. Now, what we've done here is we've removed that piece of bone that is no longer healthy. That we call this the ball of the femur. That comes off, and then you put a cup, which is made out of titanium, inside of the pelvis, and then you put a stem down inside of the femur. The new hip joint is made up of a plastic liner that lives on the inside of that cup, and then a ceramic ball. Those two things allow the hip to move with no friction and consequently no pain. In fact, hip replacement is generally regarded as the most successful surgical procedure in allowing patients to go back to activities, second only to heart bypass. So, this is one of the things we love to brag about in orthopedic surgery because hip replacement, a lot of people come in and they say, "Man, I can't believe I need a hip replacement." This is maybe they're really upset that they have to have hip surgery. The reality is, and the hip is a frustrating joint because there just really aren't a lot of other good options. Injections tend to be very disappointing inside the hip. In fact, let me go back here a little bit. You could imagine that injecting some lubrication gel or some steroid into this bad hip isn't going to make that better. In fact, at best, it might delay it for a few weeks, but it's not going to significantly change what's happening in there. In fact, really, the only way to improve a bad hip is to replace it. But the good news is hip replacement is very successful. In fact, the 10-year success rates are far greater than 95%. In fact, they're closer to 98 or 99%. And in 2025, it's even better. In fact, those 10-year success rates of 95%, those are data from the early 2000s. We've got data now that suggests, again, that almost all patients are getting better. In fact, a common theme I'll hear from patients is, why did I wait? Why didn't I get my hip replaced sooner? Because a hip replacement allows you to go back to doing all the things you did before. In fact, it even allows you to go back to doing some things maybe you haven't done before. So let me talk to you just a little bit about some of the things that are better about hip replacement. And then, like I say, we'll get to knee replacement here in a little while. Approaches. The approach is the way that we put a hip replacement in. It's where the incision is at, and it's the way that we get down to the hip joint itself. There are several ways to put a hip replacement in. Now, traditionally, you could do it from the front. We call this anterior. You could do it from the side. That's called lateral. Or you could do it from the back, which is called a posterior approach. Like I say, traditionally, about 70% of the hip replacements are done from the back or from the side. 50% from the back, 20% from the side. One of the things that's been changing in hip replacement recently is that more surgeons, and I think this is as a younger generation of surgeons sort of comes up, more surgeons are going from the front. At our recent meeting, the hip and knee surgeons meeting that I just got back from 2 weekends ago, we found that about 60% of surgeons now do joint replacement or hip replacement from the front, also known as anterior. You may have heard of the anterior approach. If you search online or you Google hip replacement, you will almost certainly see the words anterior hip replacement. That means from the front. There are some advantages to doing it from the front. So I thought I'd spend a little bit of time talking about those. First, the incision is smaller. Dick Rothman, bless his soul, and may he rest in peace, one of my mentors, taught me almost everything I know. But Dick Rothman was sort of famous for making these really long incisions. Back in the 80s, and even the 90s, the idea was is that the bigger incision, the better you could see. Nowadays, we make incisions that are much, much smaller. In fact, most of our incisions are less than 4 inches, which is, if you really consider what we're getting done through that incision, really remarkably small. Another advantage of an anterior hip, we don't have to cut any muscle. When you do hip replacement from the front, there's a window or an interval, if you will, that allows us to get into the hip without cutting the muscle. We are able to go between two different muscles, leaving them intact, do the hip replacement, and then those muscles go back together. That means quicker recovery. There's no muscle to heal. You're not waiting for the muscle to heal. You can use it immediately. In fact, after hip replacement, you'll be up and walking right away. In fact, within a few hours, you're climbing the stairs and walking in the hallway. Another advantage is that the hip replacement from the front is very stable. Stable means that it's less likely to pop out of the socket. You know, a hip replacement, there's always that possibility, but doing it from the front, doing the hip replacement for the front, decreases the likelihood that that hip could dislocate. And so it allows us to let patients do many more activities that previously might have put their hip at risk. In fact, now you may have heard of hip precautions or hip limitations. You know, back in the 80s and 90s, hip replacements done through the posterior approach, patients very often had to do what were called precautions. They were not allowed to bend past a certain degree. They were not allowed to bend over and pick things up. There was a whole host of things that they were not allowed to do. And different now, anterior hip replacement, we send patients home with no limitations. In fact, we tell you, go live your life. Some of my patients have taken that to an extreme. I've got one lady who loves to kite surf. I don't know if you've ever seen videos or pictures of kite surfing. That still makes me a little bit nervous. But we have patients who are running marathons on their hip replacements. Hip replacement really has changed drastically from what it was even just a few years ago. In fact, when I started practice, the way we approach hips and what we let patients do after surgery are much different than they used to be. This is a sort of an artist's picture showing what we call the anterior approach, where we go through the front. Your incision, again, would not be that big, but you can see how we've taken and sort of pulled these muscles apart without having to cut any of the muscle. This allows for the quicker recovery and a much more stable joint after hip replacement. And like I say, no restrictions. You know, when you get your hip replaced, you don't want to live the rest of your life thinking, I can't do that or I can't do this. Uh, our guidance after hip replacement is go back to doing everything you love to do. And in fact, try doing some things maybe you haven't done. Using your hip and going back to the activities that you love is the whole purpose. So, no restrictions. When you have your hip replaced, please, I tell my patients, try and forget you ever had your hip replaced. In fact, I just saw a lady today. We did her hip replacement 13 years ago, I think. She was here for her other hip. And I had a student with me, and she said, really, I forgot that I had my hip replaced. When somebody asks me, I still have to think it's almost like it was a dream that I ever had my hip replaced. That's what I call a successful operation. You're not thinking about it, you're not letting it restrict you, you're going back to doing all the things that you enjoy doing. Again, modern hip replacement is a quick recovery. Like I said, you'll be up walking on it immediately. Within a couple of hours, you'll be climbing the stairs, you'll be walking in the hallway, putting full weight on your hip. One of my favorite times is to go see patients immediately after surgery, the first time they put weight on it. It's very common for patients to say, it feels better on the first step. The first time they put weight on it, they'll say it feels better. Most patients go home the same day. Again, this is different. Back in the day, people used to stay 2, 3 days, was not uncommon. Now patients are going home on the same day of surgery. In fact, 60% of them go home on the same day. Once you get home, your only therapy after hip replacement is to walk. Every day, go for a walk. Our goal is to have you walking a mile by 2 weeks after surgery. Now, if you're not a walker, that's okay. We can start slow. But every day you'll go a little bit further, and by 2 weeks, like I say, if you should be able to walk a mile after hip replacement. I include this video. This is a patient of mine. He is, excuse me, he is 2 months out from his hip replacement. Now, I'm going to tell you in advance, most hip replacement patients can't do this. I can't do this. But it just goes to show what is possible. So for those of you who do box jumps, again, not me, but if you do, that's that's a 36-inch box, which is really high. The thing I love about this video is that his hip replacement, the one we had replaced just 2 months prior to this, is the left hip. And if you watched that video, if you noticed, he was getting down from the box with his left hip. And I love this because it goes, again, it testifies to what's possible after hip replacement. Now, will you be able to do a 36-inch box jump? Probably not. But could you? It's possible. And in fact, we try to encourage patients to do anything and everything they'd like to. I've got many patients, several, who have run marathons on their hip replacements. Which leads me to one of the other new changes. We have new plastics. Again, here you see the picture of a hip replacement with the stem, and you can see the plastic liner here, and then you see this ceramic ball of the hip replacement. Traditionally, the plastic, which is the part right here, was the weak link, so to speak. Hip replacements used to last about 20 years. Now, you would occasionally find one that lasted longer than that, but for the most part, that number was pretty accurate. 20 years after hip replacement, the plastic would be worn out, and we'd need to do something to address that. That made surgeons a little cautious when telling patients what to do after surgery. We used to tell them, you could play doubles tennis, but don't play singles tennis. You can walk, but don't run. We were trying to prevent that plastic from wearing out. Well, about 15, oh, it's almost 20 years ago now, we switched to a different type of plastic. And the plastic now lasts about 50 years. In fact, we think it'll be even longer than 50 years, but we can say conservatively that we think that the plastic should last about 50 years. What that means for most people is that it will almost certainly last you the rest of your life. Number one. Number two, no more restrictions. So if you want to play singles tennis, go for it. If you want to run a marathon, go for it. I often tell my patients that think of it as a challenge. I challenge you to try and wear out the plastic in your hip replacement. I've been in practice for 17 years now, and I don't know that I've even seen one patient who's worn out their hip. In fact, I should offer a cash prize for the first person who's able to wear it out. But so far, nobody has worn out their hip. So after your hip is replaced, your job is to try and forget that we ever replaced it. There are a couple of things that are new to both hip and knee replacement. And I want to talk a little bit about those. One of them is what we call epidural anesthesia. Epidural anesthesia is the way that we do the operation. It's the way that we are able to put you to sleep during surgery. You're actually awake. And you can see there's an asterisk there because you're not technically awake. That we give you what's called a spinal or a little bit of medicine in your back, and you're unable to feel anything below your waist. Then we also give you some sedation. So it's not like you're participating in this. The beauty of epidural anesthesia is it's much safer and it's much gentler for patients. Sometimes people wake up and all kinds of crazy things happen when you're under general anesthesia. When you wake up from spinal anesthesia, it's like you just took a little nap. In fact, I don't know, many of you may have had a colonoscopy. We give you the same medicine that you had during a colonoscopy, just a little sedation. There's lower risks, and when you wake up, you have less pain. It's a much more gentle way of doing hip replacement surgery, and it's made the recovery much better. Now, let's transition to from hip arthritis to knee arthritis. I got a picture here showing an x-ray on the left, and then on the right is an artist's rendition of perhaps what that x-ray would look like. Knee arthritis is similar to hip arthritis in that it's the loss of space that is the problem. A normal, healthy knee has space between the bones. That space is cartilage. Good space means good cartilage. Healthy space means healthy knee. As the space goes away, and you can see on this x-ray and also on this drawing, the bone has started to rub against itself here. A couple of things happen when the bone starts to rub against itself. This particular patient is probably bow-legged. As that space went away on the inside part of the knee, the leg started to bow. It can also happen that the space goes away on the outside part of the knee, and the patient's knee starts to get knock-kneed. Both of these are signs of advanced arthritis. We turn and knee or knee arthritis is treated with knee replacement. We turn this, and again, you can see sort of these classic findings. The space is getting very narrow, almost bone on bone touching right there, into this, which is a knee replacement. Now, we're mostly talking about surgical treatment of knee arthritis tonight, but I think it's worth mentioning, unlike the hip, there are some things we can do for knee arthritis that don't involve surgery. I'm sure many of you have heard of a cortisone injection or gel injections. Those things can be helpful for patients with early arthritis in the knee. So, before you need a knee replacement, it might be wise to try some of these things, and we do this on a daily basis. But so there are some other things besides knee replacement to help treat hip or to treat knee arthritis. So let's talk about again what's new when we're talking about surgery and we're talking about joint replacement and especially knee replacement. One of the things that's been sort of a game changer is what we call a periarticular injection. In addition to the spinal anesthesia that we talked about, the anesthesiologist will put some medicine around your knee that is designed to keep you comfortable for about 3 days. We call this a block. The block makes it so that when you wake up, you really have minimal pain. In fact, patients immediately after surgery wake up like they say, Doc, my knee hasn't felt this good in years. And that's just immediately after surgery. It allows them to get up and walk. It allows them to climb the stairs right away. And ironically, it's walking sooner, climbing stairs, being more active that also decreases the risk after knee replacement surgery. Because moving, it turns out, is the most important thing you can do. So, a block that allows you to move quicker also decreases risk. Now, you're probably thinking, well, what happens when that block wears off? The block does wear off. Unfortunately, we do not have a way of blocking the pain permanently. But we do have a way of keeping it comfortable for the first 3 days. During those 3 days, you'll be getting started with physical therapy, and we'll be starting with some pain medicine so that when the time comes when the therapist is pushing on that knee, there's some pain medicine and some alternatives available to help so that you feel better. We also do what's called a rapid recovery program. And the only way I can sort of paint this or explain it to you is to describe how things used to be. Back when I was initially doing my training, after knee replacement, patients woke up with a giant wrap on their leg so that the whole leg wouldn't move. In fact, they had a drain coming out of their knee and they would lay in bed for the first 2 days. They weren't allowed out of bed for 2 days. They had a catheter in so they didn't have to get up to go to the bathroom. And they used to have this machine called a CPM, which was a constant passive motion. It basically would bend their knee back and forth, back and forth, back and forth. And then they had a little button that they would push to get morphine. And literally, they didn't move for 2 days. It's no surprise that patients had high rates of blood clots when they're not moving for 2 days. When you sit around and don't move, bad things happen. Now, about 15 or 20 years ago, we figured out that probably that wasn't a great idea. In fact, we were doing things exactly the wrong way and encouraging patients, in fact, even pushing patients a little bit to move faster was the right way to do it. We call this rapid recovery, but it's a whole program of trying to encourage not just the patients, but also their families that the knee after surgery is healthy. It needs to be used. In fact, one of the things, the most important things I tell my patients, and I want them to remember when they're recovering from surgery, the knee is pretty much full strength as soon as they wake up. You do not have to baby it. You don't have to be cautious with it. In fact, I encourage you to do anything and everything you want. We always tell patients when you call and ask, can I do this? The answer will be yes, which gets to the point. There's only one exception to that. And it's sort of ironic that the picture I included here is this woman out on a jet ski. We don't want you in the water. And in particular, for those of you who are down at the shore, we definitely don't want you in the bay or the ocean. That is the one thing we should tell you to avoid. But besides that, we tell you get up, walk. Should I go to the grocery store? Absolutely. Take your walker with you. Make sure your husband keeps the car close in case you get tired. But do those things. The more things you do, and the sooner you do them, the faster you'll recover, and the sooner you'll be back to recovery and being back to doing things you enjoy. Another new thing that has changed is we have a couple of new medications. One in particular is called TXA, or tranexamic acid. Now, this is a medicine that we give you at the time of anesthesia. It minimizes bleeding. The reason that's really important, not only do you lose less blood, but when there's no bleeding around the joint is less swollen. When it's less swollen, it doesn't hurt as much and it bends faster. You're able to get your motion back quicker. This simple little medicine has led to patients getting their recovery back much quicker than they did in the past. Another thing that's new is aspirin to prevent blood clots. Now, this is one of my sort of favorite stories from the way things used to be. Blood clots after surgery are one of those things that everybody is afraid of, surgeons included. We've always been afraid of patients getting blood clots. In fact, I know you can't respond to me, but I'm sure some of you have heard of the medicine Coumadin, which is also known as warfarin. Back when I was in training, we gave every patient Coumadin to prevent blood clots. It's a blood thinner. Some of you may recognize that warfarin or Coumadin also has another use. Coumadin or warfarin is also used as rat poison. I mean, we were so worried that patients were going to get blood clots that we gave every single patient rat poison to try and prevent those blood clots from happening. Well, several years ago, it's been almost 15 years now, we figured out that, in fact, if we did a couple of things differently, number one, get patients out of bed sooner, get them moving quicker, that we could also give them less blood thinning medication. In fact, we could even give them something as simple as aspirin. Now, the interesting thing here is when you use aspirin, there's less bleeding, there's less swelling, there's less pain. Now, when you combine less bleeding, less swelling, and less pain, it turns out patients are more willing to get up. They're willing to move quicker, and consequently, they're less likely to get blood clots. So, switching to aspirin, moving away from blood thinners that really caused a lot of bleeding and pain, was one of the biggest, most important changes that has both made knee and hip replacement safer and faster to recover from. Another thing, we don't cut the tendon. You may have heard of the quad sparing or the quad preserving knee replacement and not known what that was. I show here on the right is what we do as a traditional knee replacement, where this blue line is where the tendon is divided and the way that we get into the knee. The quad sparing approach, instead of cutting up here along the edge of the tendon, we go off to the side of the muscle. That preserves this muscle so that you can use it immediately after surgery. So when you'll hear patients or you'll see ads or you'll hear doctors talk about quad sparing or we don't cut the tendon, this is what they're talking about. This leads to a faster recovery because if that muscle's not healing, you can use it. This is how you're able to get up and walk right away. This is how you're able to climb the stairs right away. This is how you're going to be able to move more so that we have less risk of blood clot. These are the things that are making the recovery faster. I also wanted to talk about robotics. I'm sure many of you have heard about robotics. You know, when you think of a robot and what kind of a robot we use in the operating room, I'm not sure if you picture something like this, which is kind of a child's toy, or something like this, which maybe this is our future AI robot. I don't know. But neither of these are what we use when we talk about robotics in the operating room. Surgical robots look more like this. And these are some of the examples of the surgical robots we use in the hospital every day. The robot, and you'll hear people talk about robotic knee replacement. In reality, the robot isn't really doing the knee replacement. The surgeon is still doing the knee replacement. The robot is just sort of helping us know where to make the cuts and know what angle we should make the cuts at. And so the robot helps us to be more precise. I wanted to talk a little bit about what robotics is, but also what it's not, because there is some misinformation out there. The first thing is robotics is not new. This has been around for about 15 years. Now, it's gotten better. It's like your iPhone. It's much better than it used to be, but it's been around for a long time. So it's not something that's new. Another important thing to point out is the robotic surgery is not necessarily less surgery, meaning we still have to make the same cuts. The knee replacement that we put in during robotic knee replacement and the knee replacement that we put in traditional knee replacement is the same implant. The parts that go inside are exactly the same. The only difference is how we make those cuts. Again, the robot helps us do that on robotic surgery, and then we have what we call traditional instruments that help us in non-robotic surgery. It also brings up another point. There are a couple of extra incisions. And so I just want to make clear because my patients who have robotic surgery sometimes are surprised if there are two extra incisions that we have to use to put what we call pins into the bone to allow the robot to know where it's at. So there are a couple of extra incisions that are associated with robotic knee replacement. The robot is not necessarily a faster recovery. Now, I also point in there, or I point out, it's not necessarily because I think we're making strides. We're doing things with the robot that we've not been able to do in the past, which we think may eventually lead to faster recovery. But again, patients are recovering so much faster now that it's hard to know which thing is making them recover faster. But the robot, again, same cuts, same implants, the recovery may or may not be a little bit faster. And this is the other one. The robot is not necessarily proven. You'll hear all kinds of claims. When you study and you actually go look at patients and you compare them head to head, who's had robotic surgery, who's had traditional surgery, which of those groups is doing better and recovering faster? You won't be surprised to learn that they're actually almost exactly the same. And again, there is some opportunity for improvement in the robot, but as of 2025, traditional knee replacement and robotic knee replacement end up with about the same recovery. And one caveat too, robotic surgery is not cheaper. And this is one that I always want to point out because depending on your insurance plan, a robotic knee replacement does require what's called a CAT scan or a CT scan to help us map out the knee and to map out the joint. That may add to an additional cost. It can be as high as $500. You have to check with your insurance company. So, again, these caveats we make sure we point out to patients so that they're not surprised by any of these charges or that they know what they're getting into. Now, what robotics might be, and this is the part that's exciting for me as a joint replacement surgeon. Robotics might be better. We're figuring this out. We're doing things in a way that might be able for us to make smaller incisions, might be able for us to make more precise cuts. A robot can do things with very accurate guides that we sometimes struggle to do with traditional guides. Like, for example, say that the knee replacement needs to be cut in 1.2 degrees. I can cut 1 degree and I can cut 2 degrees, but 1.2 degrees, that's a level of accuracy that we have not had in the past. And so robotics opens up possibilities that we have not had before. And so that's an ongoing story. And maybe in 10 years, we'll be able to tell you what the results are and how this ended up. But right now, we're discovering it and exploring it. It's a very exciting time to be in joint replacements. To me, I sort of equate it to electric cars. Again, electric cars, although many of you might drive an electric car now, they are not new. In fact, this is one of the original electric cars. This was in 1965. This thing, I think, went 30 miles with a top speed of 27 miles an hour. Was it electric? Yes. Did it use gas? No. But still, probably not great. 20 miles at 25 miles an hour, 30 miles of range, not great. This is a more modern electric car. This is from the 80s. You can decide if you like that, if you think that's beautiful or not. I think it's a little ugly, but this thing could go up to 50 miles an hour and had a range of up to 80 miles. Again, better, but not perfect. Now, that said, there's always been some uses for electric cars. You know, the original car that they used on the moon was electric. Sometimes electric is better than gas. What I'm trying to equate this to, though, is robotics and knee replacement surgery. I'm not sure if we're here or if maybe we're here now. This is the new Tesla Roadster, which goes up to 600 miles in range. It can go 150 miles an hour. It's as good as a new car, as a gas car, and in some ways maybe even better. So we're still figuring that out with robotics. One of the most important changes, and I know I'm running out of time, but same day surgery. You know, when I started doing knee replacement and hip replacement, patients typically stayed in the hospital for 3 days. About 70% of patients went to rehab. Many of you may remember Bacharach rehab, went to rehab after surgery. 70%. Around 2017 or 2018, the hospital where I work at, which is Atlanticare down here at the shore, came to us and said, we'd like to build a facility where we could do joint replacement on what we call an outpatient basis, where patients go home. We titled it the Center for Orthopedic Surgery. We're going to call it COS. And they said to us, how many patients, what percentage of your surgeries do you think you could do in the patients and that go home the same day? We thought if we dreamed big, we thought, what's the most we could imagine? Probably it was 20, maybe 21% of people, one in five, could go home the same day. And so we built the Center for Orthopedic Surgery. This is a picture of it. This is the new building. That's not new. It opened in 2020, just in time for the pandemic, and then it closed for a year. We didn't actually start doing surgery there until 2021, but now we're 4 years and counting doing hip and knee replacement in this outpatient facility where patients are going home the same day. What's interesting is, like I say, we've been doing it for 5 years now. We do almost 2,000 surgeries per year. Now, you remember, we said that we could probably do 20, maybe 21% of patients. Well, in 2025, this year to date, we're about 63% of patients are going home the same day, which I'm going to tell you, even 5 years ago, if you'd have told me that we'd be doing 63% of our patients, I would not have believed it. The best part about it is not only are patients going home, not needing to spend a night in the hospital, they seem to have less pain. Because in order to get patients home the same day, we had to make some changes to what we were doing. We had to introduce less invasive techniques. We had to come up with blocks that allow patients to be comfortable. We had to do things that allowed them to get up and walk so they could be safe at home if they needed to get up and go to the bathroom by themselves. Patients also seem to have fewer complications. One in particular, I told you we used to do catheters, which is a tube that goes in your bladder so that if you have to go to the bathroom, you don't have to get out of the chair. Now, we don't have to do that at all. In fact, we don't use catheters for anybody. But we were always worried about patients not being able to use the bathroom after surgery. That would happen occasionally at the hospital. Well, when we do it at the Center for Orthopedic Surgery, we do a shorter acting spinal. The anesthesia lasts less time, and consequently, patients are able to go to the bathroom. Now we have almost no evidence or no incidence of urinary retention. It just doesn't exist anymore. And the Center for Orthopedic Surgery really did solve that, made it possible for us to do that. And I think this is the most important one. Patients seem to like the experience better. When you go for a joint replacement, and some of you on this presentation may eventually do that, you'll see when you get home, you'll get a survey, and we routinely look at those surveys and find out what patients liked and, more importantly, what they didn't like. But the one theme that seems to stick out is that the patients who go to the Center for Orthopedic Surgery seem to rate their experience better. It turns out that people would like to be at home. They'd like to sleep in their own bed. They would like not to have somebody waking them up at 2 in the morning to check their blood pressure. These are all things that lead to better experience, and the Center for Orthopedic Surgery has allowed us to do that. So, who's a good candidate for the Center for Orthopedic Surgery? In general, it's healthy patients. There are a couple of medical conditions that if you've got one of those, it may not be a good idea to do your surgery outpatient. A history of kidney disease, if you've had a heart attack or a stroke or something along those lines. There are some people who do need to go to the hospital, and the hospital is a great experience too. And so there are often people who say, I live at home alone, I don't have a lot of support. That's fine. You can go to the hospital, spend a night at the hospital. But if you're motivated to go home and you have somebody who can spend the night with you that first night, then the Center for Orthopedic Surgery or outpatient surgery might be a good way to do it. And I think that we're finding that more and more people, as they do this, they like that way and they're happy that they did it that way. So we're just a few minutes longer than I promised. I apologize for running over. I wanted to make sure we reserved some time for questions because I hope there are some questions and I'd like to answer as many as we possibly can. We've got about 15 or 20 minutes before we got to wrap up. So Kristen, are you gonna read the questions for us?
I'll read the questions. That was really great. I've sat on so many of these, and I always learn something new. That was great. Thank you. Okay, we'll start off nice and simple. Can exercise help with arthritis pain?
That's a very good question and a hard one to answer. Yeah, the short answer is yes. The two things have been associated with decreased arthritis pain. Number one is weight loss. I mean, it's simple mechanics, right? The more weight you're carrying on your knees or your hips, the more likely you are to have pain in those joints. And so, one thing that shows up over and over and over again that decreases hip and knee pain is weight loss. So, if exercise helps you to lose weight, then that's a great idea. The one caveat to that is, Kristen, I really don't think it's a good idea if you're hurting, meaning you think, man, it kills me to go walk the boardwalk. My knees are really hurting me, but I got to do it so that I can keep my exercise up. That's probably not helpful. There really does come a time where it's like the tires are bald and driving faster just doesn't help them. So that's probably an important conversation to have with your orthopedic surgeon, looking at your x-rays and sort of figuring out where on the spectrum you're at in terms of how bad your knees or your hips are, because getting them replaced might allow you to go back to doing that exercise, which is good for your heart and your brain.
And in the meantime, maybe try like, swimming or something that's not, hard on your joints.
There are some exercises. We always say smooth, fluid motion, biking, pretty gentle, elliptical, swimming, things like this.
Jumps, no, probably not. Is epidural anesthesia still possible for patients with AFib and post-TAVR?
Yes, yes. There are a very few couple of things, and the anesthesiologist can discuss this with you, that make it so epidural anesthesia is probably not a great idea. But I'm talking 99.9% of people can have epidural anesthesia, including people who've had a TAVR or people who have AFib. In fact, we really push in every situation, if at all possible, we would like the patients to get epidural anesthesia.
Can you talk about the pros and cons of an anterior approach versus a posterior approach?
Yeah, we went over this a little bit, and I have to disclose my bias. I do the anterior approach, and so of course I think it's better, right? We think what we do is the best. I think the advantages are, if I can shorten it, the hip is more stable, meaning the hip is less likely to dislocate or have problems with stability from the front. When you do it anterior, it's easier, it's more stable for the hip. Number two is that the recovery is a little faster, and what we call the gait mechanics, the way you walk, comes back more naturally and quicker than it does from a posterior approach. The other thing, and let me just point this out, it's easier to make sure your leg lengths are the same. And that sounds like that's a complicated, surgery type of thing. But one of the things we do in hip replacement is make sure that we get your leg lengths the same length. When you're doing that from a posterior approach, that can be challenging just because of the way you have to be positioned during surgery. So an anterior approach gives us a better opportunity to make sure those legs are exactly the same length.
Oh, that's interesting. Um, if you have both hip and knee pain, which one would you do first?
So the general rule is hips first. And the reason is you remember hip replacement, the therapy is just to walk. It's really all you got to do is walk. Knee replacement is much more involved. You'll be meeting with the therapist 2 or 3 times a week. And so if you've got a painful hip and you're trying to do the knee therapy, that might be limiting. Whereas if you've got painful knees and all you've got to do is walk, that might be a little easier. So general rule, hips first and then knees.
Um, it says Dr. Post sounds much more positive about hip replacement versus knee replacement in terms of simplicity and recovery. So I guess this is kind of tied into the last one, but there's probably a little more to it.
Let me explain. I didn't realize I had betrayed my bias. The truth is I think if people who've had hip and knee replacement, most people would say that the hip replacement is a little bit of an easier recovery. It's true. It really is. I mean, you just have to walk, and the more you walk, the better you feel. A knee replacement requires a little bit of a commitment because you're going to be meeting with therapy, and that therapist is going to be both your best friend and your worst enemy because he's going to push and he's going to push and he's going to push. But I think in the end, both hip and knee replacements do it great. It's just those first few weeks after knee replacement require a little work, a little bit of commitment to really getting that knee moving as much as possible. But yeah, somebody's paying attention because that was
They're
that they
noticing.
figured that out. Yeah.
What about does soft wave or red light therapy help with hip or knee arthritis?
Again, there are a whole great question because there are a lot of these things that you'll hear about both online, you'll see it in magazines, or you'll hear friends talk about, oh, this or that. Most of those things are unproven. Um, Meaning when we've done those things and we've compared them to placebo, meaning, some patients get fake red light or they get something else and then the other patients get the real thing, there really is no difference. And so the evidence that those things help is minimal. It's sort of how you can figure out is if you look at the things that the insurance company pays for. Insurance companies, we all hate them, but they pay attention to what the data is. And so if there's no data that those things help, then they are not going to pay for it. And so if you're having to pay cash or out of pocket for these sort of fringe procedures, it's probably a sign that those things haven't been proven to work, that they don't work effectively. So I always caution patients, if you've got a bunch of money that you just love to throw away, try those things.
Right.
Otherwise, it's probably a good idea to discuss them with the orthopedic surgeon because it breaks my heart to see patients come in and they spend a bunch of money trying these kind of alternative treatments and then they just didn't get any results. And they're out 3 or 4 or 5 thousand dollars, and it just breaks my heart because you look at their X-ray and you think there was no chance that was going to work. But patients are desperate, and so sometimes
Right.
they
Right.
do things that, hoping that it'll work. But the evidence
So I
just
guess like a good way to decide is, FDA approval. We're looking for
FDA
things that
approval,
are
right?
approved. Hmm.
If you submit it to your insurance company and they say, "Yeah, we cover that," great. That means there's evidence that it works. But when you see these ads on Facebook or you see some posts on Instagram or something like that, you should be a little skeptical because the reality is most of those things have not been proven to work.
Right. Um, a friend had robotic knee replacement 4 years ago and is still having nerve pain. Is this different than with robotic versus traditional? You didn't mention anything about cutting nerves.
Yeah. So we always try not to cut nerves. The one difference between robotic and non-robotic, again, I mentioned those pins. For the robot to know where it's at, the pins have to be placed in the thigh and in the lower leg. And there have been some cases described where those pins rub up against a nerve and cause some nerve pain. Again, your surgeon, I promise you, is trying to avoid that. But that is one of the small, rare complications that can be associated with it.
Why would a doctor not offer a nerve block post TKR, referring to a Rothman doc who said he does not do them?
Yeah. Again, my bias, we do the nerve blocks. And so I fully admit I'm biased. I think they work better. There's some concern that patients are going to be comfortable for 3 days. And then when the block wears off, they're going to be unhappy because they're going to be in pain. Um, like I say, I've always sort of taken the approach, man, if it lasted for 5 days, I'd take five, right? But since it only lasts for three, I'll take three. It's just an opportunity for you to get home, get established, get things set up in the house, get your routine down, get to therapy before that pain really sets in. And so there are some surgeons who are concerned that, man, I'm false advertising. These patients go home and so happy, and then 3 days later they're miserable. And that's not necessarily true, but I think that's the worry that doctors are worried that patients, when that block wears off, they're going to be in pain. To me, it's 3 days of sort of pain-free opportunity to get started on your recovery.
Yeah, yeah. I agree with that. Not that I know anything, but that sounds good to me. Um, do you have experience with PRP? This probably goes along with the FDA stuff. Just wondering if there are any surgeries that or any therapies you could recommend that don't involve surgery.
Yeah. So the therapies that have been shown to help, steroid injections, these can help. Again, they're limited. They don't last for as long as we would like them to, but they can help. There are gel injections which can help. PRP, I'm afraid, falls into one of those categories where commonly not covered by insurance. It's often an out-of-pocket cost. It's funny that they phrase that question, do you have experience with PRP? I actually do have personal experience with PRP. I grew up out west, and so I like to ski. And several years ago, I had a knee injury where I tore my MCL. And one of my partners, who is a big advocate for PRP, said, "Let me give you a PRP shot. It'll be great. Your knee will be so much better." And I can tell you without bias, because I lived it, that was maybe the single most painful thing I've ever experienced in my life. It was really not pleasant. And so when people ask me about PRP, I always have to say, I did that. It was very painful and it didn't help. And again, when you start comparing PRP to patients who got what we call placebo injections, just saline, and everybody's blinded, nobody knows what they got, they turn out to be the same. They really don't help. So if you can get PRP and it's not very expensive, try it. I'd be cautious before I spend $2,000 or $3,000 for a PRP injection because the evidence that those things help just isn't there.
And to go through that pain, I mean, it's one thing if you have a good outcome, but to go through the
It didn't
pain and
help.
then
It
not really
was
have
painful.
relief.
Yeah.
Do you secure the knees with cement?
Yeah. So there's two ways to secure a knee. You can do what's called a press fit or a cementless knee replacement, and then you can use cement. In general, cement lasts for about 30 years. So we sort of do the math and we say, listen, if you're in an age range where the knee lasting for 30 years, let's imagine you're 75. At 75, cement probably makes sense, right? It's going to last you until you're well over 100. It's probably a good choice. Now, if you're 55, cement may not be a great choice because 30 years puts you to 85. And so you can use a cementless knee. There are some disadvantages to cementless knee, but your surgeon is probably always sort of thinking along those lines, being, what's going to be the best thing for you? What's the thing that's going to last you the longest and give you the most or minimize your risk as much as possible? So, older patients, and I use that term lightly because, you know, we're all getting older. But if you're young, under the age of 50, definitely cementless. If you're over the age of 75, definitely cement. But other than that, we're trying to make sure that the implant and the way we fix it is what is best for you.
Um, is there a way to bypass the steroid and gel shots, or do most insurance companies require those first?
Yeah, so they're not actually required. That's a good question because some patients come in and say, "Listen, I know where this story ends. I know I'm going to get the knee replacement eventually. Putting it off a few months doesn't really help me. I just soon get it over with." And that you can do that. It's not required to do the gel shots or the steroid shots. In fact, many patients say, "I don't really want to do that." So if you're not interested in that, your surgeon or we can sit down and talk about it. And that's a pretty easy case to make to the insurance company and say, listen, they get that. They know that it just delays. It doesn't actually eliminate, it just delays. And so typically they're not giving us too much trouble to just skip the shots if you want to do that and go straight to surgery.
Can you talk about weight and BMI as it relates to moving forward with surgery?
Yeah, so there are a couple of restrictions. BMI, for those of you not familiar with it, is a relative height to weight ratio, right? If you Google it, you'll be able to look and you can put your height and your weight in there, and it'll tell you what your BMI is. Um, the hospital has set some restrictions. Currently, that's about 40, a BMI of 40. Of note, a healthy BMI is around 25. Most people who you would look at and say are healthy weight are somewhere between 25 and 30. So a BMI of 40 is just means that you've got extra weight. We will work with patients because there are patients who, I mean, this is a difficult issue, right? It's a tough thing. And so there are some patients who are carrying some extra weight. We really want to get that down because the evidence shows that they're more likely to have trouble after surgery if their BMI is too high. So we work with a nutritionist. There are these new medications, Ozempic, you've probably heard of these, which have been very effective to help patients get that BMI, that body mass down a little bit before surgery. And then the hope is that once the hip or the knee is replaced, now you can walk better without pain, helps you to keep that weight off naturally. You can just be more active.
What can you say about the Agile C Carfith heel implant for knees? Car Carf to heel? I don't know what that is.
I'm not sure if I know exactly what that is. Um, Knee replacements are, if you look at knee replacements that we use now and you compare those to ones we used 20 years ago, on the surface, they look very similar. In fact, they are very similar. They really haven't changed. Knee replacement hasn't changed a lot. There are a couple of little technology changes, like the plastic. Plastic lasts much longer now. But the actual mechanics of the knee replacement are very similar to what they used to be. In fact, knee replacements have sort of become a little bit like cars. They're a little bit of a commodity, right? There's not too much difference between a Toyota or a Honda or a Ford or a Chevy. But finding out which one fits you the best is probably a discussion to have with your surgeon. And I always tell patients, the knee replacement that fits you best is the one that your surgeon and you agree on. and the one that he feels most comfortable using in his hands. You want the one that they do every day, the one that they feel confident they could get in and put in comfortably that's going to work for you for the longest time possible.
Perfect. Okay, we'll just do a couple more here and then we can wrap up.
Absolutely.
Um, can someone with a nickel allergy have a knee replacement?
Yeah. So this is another question that is a little bit complicated. Nickel allergy is common. If you look at patients who can't wear cheap jewelry or they get rashes in their earrings or things like that, it's not an uncommon thing. And most knee replacements do have nickel in them. There is a knee replacement that is made out of ceramic. So if you've got a history of metal allergy, that's a conversation to have with your orthopedic surgeon. Because, like I say, there is one specific knee replacement that we can use that is tailor-made for patients who have nickel problems or issues with metal allergy.
Okay. What about kneeling on the knee after a
Oh,
replacement?
great question. Great question. I just had this conversation today. I've had a guy who needs a knee replacement. He works in an HVAC. He says he's in crawl spaces, he's climbing all over houses. He needs to be able to kneel. You will hear some people say you can't kneel after a knee replacement. Actually, the reality is that's just not true. You can kneel. Some people find it a little uncomfortable because when you kneel, that incision for your knee replacement is very close to where you put weight on your leg when you kneel. I tell patients I've got a handful of patients who their jobs require them to kneel. One guy is a concrete finisher. I mean, he's literally on his knees all day, every day. He's got both knees replaced. He kneels without any issues. So I think the take home is it might feel a little funny at first, but if you push forward with it, you'll be able to eventually kneel with no problems at all. And the most important thing is you won't damage your knee by kneeling on it. The evidence is overwhelming in that sense. You won't hurt the knee if you kneel on it.
Okay. And we'll take this as the last one. What about having to repeat or hit a hip or a knee? And why? How often does it happen and why would it happen?
Yeah, there's a whole host of reasons. There are about a million possible reasons why. The most common ones are that the implant becomes detached from the bone. We call that loosening. Very rare, probably 1 in 2,000 or so, I would guess. Or an infection. In spite of our best efforts, and we make serious efforts to prevent infection, on occasion, about 0.4% of the time, infections will happen. And so that might require additional surgery. But again, your surgeon or whomever you're seeing or working with is going to do their best to make sure that that risk is minimized, that we make it as low as possible.
Wonderful. I think we'll wrap up there. Thank you so much. That was really, really informative. And like I said, I learned something new every time. So thank you.
I appreciated doing it, Kristen. Thank you. And thanks to everybody. And I know I can't see you, but if you have further questions, I'm sure Kristen can help you get appointments to see me or any of the joint
Yeah,
replacement surgeons at Rothman. We'd be happy to go over the details and look at your x-rays specifically and answer any of your specific questions as they apply directly to you.
wonderful. Thank you, everyone. My information is in the Q&A box or the chat box. And also everyone should have my email because you got lots of reminders about this. Again, thank you so much, Dr. Post. It really was great.
Have a good night, everybody.
All right, take care.